University is organizing as a sort of modest way, if you like, for the center to engage with, what's on everybody's minds, and context of the pandemic. And this is the very first in the series of webinars that the center is organizing, and we are extremely fortunate to have Martin Ravallion actually as our inaugural speaker. Before I turn it over to Martin, let me just briefly mention that, as I said, this is the first in the series. We starting next week, following this one, we also have a range of webinars that are at various stages of planning and on different topics intersecting with the pandemic context. And in particular, we are looking to organize webinars on the themes of gender. There's going to be one on India, in fact, next Monday. And then we also plan webinars on focusing on East Asia. There's another one on South Asia, and two other webinars focusing on broadly on the themes of food security and the context of the urban context, the context of cities, the implications of what we are experiencing in terms of what it means for the future of cities. So Martin, of course, his name is well known to every serious student of development economics, so I don't need a lengthy introduction. But just very briefly, Martin holds the Edmund D. Villani Chair of Economics at Georgetown Universities. Prior to that, Martin has had a very distinguished career at the World Bank, spanning some close to 35 years, and really has shaped, has had a really influential role in shaping research agenda within the World Bank, which he continues to influence from Georgetown University as well. As I said, we are extremely lucky to have Martin as our inaugural speaker. Our focus, being the Center for Development Economics, is also, we want to focus as much as possible on the developing country context, as the pandemic is now widely expanding to developing countries as well. Let me just mention a few ground rules and then hand it over to Martin. And mainly, I just want to say that, if you could keep your audio muted through the presentation, that would be good. You can ask questions throughout the webinar using the chat function, and I will be actually collating some of the questions, and then we'll have time to turn them over to Martin to respond. Broadly, we'll let Martin have the floor till about 10:45 and leave the last 15 minutes for questions and answers. We are also recording this session, and the recording will be available at the Monash YouTube channel as well as the CDS website. And so please keep your audio muted, but the video, if you don't want to be recorded, then you can keep your video off. Otherwise, you're welcome to leave it on. So without further ado, let me turn it over to Martin. Thank you, Martin.
Thank you much. Thank you very much, Gaurav, and thank you, Gaurav, Asad, Cicera, for inviting me, and shout out for organizing everything. And this is just-in-time production. This is really Dominique van der Waal, my co-author, and Kate Brown. We've been working on this till just a few hours ago. And we're looking forward to your comments. So it's extremely timely, not just because of COVID, also because we only started this paper 4 weeks ago. Let me cut to the chase. Okay. As I said, joint work with Kate Brown, who's at Department of Economics, University of Manchester, an ex-PhD student of mine, and Dominique van der Waal. A little personal note, Dominique and I are kind of reeling today because a dear friend and colleague of ours, Adam Wagstaff, a famous health economist, passed away this morning. We're very upset about this. And Adam, I would have loved Adam's views on this paper as a health economist. But any views out there of, on this paper are very welcome. We're putting it out as a contribution to knowledge and understanding of how this amazing crisis we're in is going to impact on the developing world. And let me just give you the paper in a nutshell. What we propose here is a measure of the adequacy of home environments for protection. What we're concerned about is how can poor people protect themselves in this period before we have vaccine or antiviral treatments. What can they do? We devised an index for measuring this, and we compare it across developing countries, as many countries as we can, using the most recent data. A total of 1 million sampled households, a bit over 1 million, from the demographic and household survey, demographic and health surveys, combined with facility surveys. What do we find? It's not a very it's not good news, I'm afraid, or mostly not good news. We find that the prevailing WHO recommendations for protection are really quite unrealistic for the home environments of a huge proportion of the developing world. We only find that 10% of all households in that million households we're using for survey data have adequate home environments to protect themselves against all dimensions in the recommendations. 90% do not. We also look at the wealth effect, which I'll explain in due course. We find a very strong wealth effect. In other words, it's a much more serious problem for poor people than non-poor people. And we see that within and between countries. Just to give you an example of that, only 6% of the poorest 40% of households have adequate home environments for protection. And that proportion is virtually zero in Sub-Saharan Africa. Okay, I'm going to begin with some motivation. And then I'm going to talk about this, the kind of theory, if you like, behind this HEP index, which we're going to define. And then the empirical implementation, our results, and some conclusions and policy implications. On the motivation, well, you've all heard about the WHO recommendations for protection from the virus. These have been, they were based heavily on the literature and the experience in China prior to the virus becoming a pandemic, and ratified by numerous governments. The essence of the idea is protection, to lower the reproduction rate for the virus. The idea is basically with isolation, to break off these links. If we think of this network that I've shown you here, we're trying to break these links everywhere as much as possible. Isolation is a key part of that. There are really 4 parts. Learning, and learning is fundamental here, and I've written about this elsewhere too, that huge importance of poor people and anybody having access to information. What do they do? Or how high is the incidence in their neighborhood? What are the right things to do for protection? How do they consult to even find social assistance if they need it? Because if you're in a lockdown, you're very poor, you could easily starve. But isolating is a second. The social distancing that we're all going through, a huge proportion of the world's population, is trying to lower that reproduction rate for the virus. Hand washing, a regular hand washing with soap and water, and treatment. If key symptoms exist, a fever, difficulty breathing, other things, then seek medical help. So really what we're asking is, how feasible are those recommendations for most people in the world, in particular for the developing world? We're not criticizing the WHO in any sense, but we want to understand feasibility partly to inform policy. There's certainly an expectation at this point that the virus will spread. Some aspects of the realities in the developing world will slow that, but others not. And in fact, we'll come back to try to isolate information about the risk factors and the likelihood of spread. A lot of concerns here about the home environment, and others have written about this. I've written about it. A number of others, Andrew Jones, others in blogs, raising these concerns. And so we want to look very systematically at those concerns. Are the WHO recommendations applicable to poor countries? The first thing you notice here is that these recommendations have a huge infrastructure requirement. I mean, basically, you've got to have things about your household, the goods you own, and the nature of the dwelling and its location, which facilitate compliance with these recommendations. To anybody like us who's spent time in the field and people living in developing countries will probably find our results unsurprising, although the magnitudes may be a bit surprising and the geographic structure of the problem might be news. But essentially, all of the things I talked about, learning, isolating, washing, treatment, have an infrastructure requirement. You obviously have to have a dwelling with walls and a roof and enclosures that are feasible. The density can't be too high. Certain basic facilities, if you have to leave the dwelling or the yard to go to the toilet or get to water or whatever, that's going to make isolation difficult. And you have to have facilities for washing your hands with soap and water. You have to have access to treatment. You have to be able to physically reach health facilities. And if you're sick, that might be problematic. So that's our question. How well can the world's poor protect themselves? The basic idea here is we think of these attributes of the dwelling, including its location, as a vector of characteristics, this Z vector, and that has a cost function. There's a cost of achieving any Z vector. That cost function is strictly increasing in all arguments, and it can incorporate adjustment of costs. And we interpret the recommendations as a set of minimum values for this Z vector. And full compliance requires that you have a Z for any one of the attributes which exceeds the minimum values. We can also look at complete compliance and partial compliance with any set of requirements. This is a very obvious way to set the problem up. But we're going to think of, if you look at this equation here, we're thinking of the Z vector as dependent on wealth, the prices faced for other goods, and the Z mins, the minimum quantities of those Zs required for compliance with the WHO recommendations. We're going to define this index, which I've highlighted here, which is very simple. It basically says you have a HEP adequacy if you comply with some subset of the set of characteristics and we're going to define the set of characteristics of your dwelling and its location. And if you comply for at least K values, we say you're K compliant. We're going to also look at shares of the population satisfying each element of our index, and we're going to test robustness to different Ks and different parameterizations of the whole structure. How do we implement this? We're going to use the latest demographic and health surveys. This is a hugely important source of data on demography and health in the developing world, run out of, administered by USAID. We're using the DHS surveys the last 10 years. We just drew an arbitrary line at 2010. We've got 54 countries, so 1.05 million households. The DHS traditionally is focused on health and demographic characteristics. Here we're looking at a kind of another aspect of the survey. It's what it tells us about household infrastructure. And thankfully, it can tell us quite a lot. Not everything we want to know, obviously, but quite a lot about these household attributes of infrastructure. And we can construct a household wealth index from the survey. So I'll come back to a second survey we're going to use in a little while, but using the DHS, we're going to say that a household is fully compliant with the requirements if it satisfies these 6 conditions. It's not that there aren't, we'd love to add a few things to these conditions, but we can't because of data feasibility. But the 6 conditions are that on the learning side, you have to have at least one of an internet, a phone, land or mobile, TV or radio. You've got to have one of these things to know what's going on, to get the messages and to get updates on the messages and so on. which could also be very important for tracking and so on, and community cooperation and assistance with food. No more than 2 people per room. This is our judgment. All of these things are essentially our judgment. Any more than that, we think it would be really quite difficult to implement the social distancing within the household. You have to have your own toilet. You don't share it with other households. Without this, it obviously would be difficult to comply. Not impossible, but more difficult. The dwelling has to be adequately closed. It can't be just open. So we interpret that as solid walls and ceiling. You have to have water piped into the dwelling or the yard or some private source so you can get your own water. And you have to have a private place in your compound, in your yard or in your dwelling for hand washing with soap. So those are our requirements. As you probably, some of you are probably thinking, in a sense, what we're doing is asking a few characteristics of poverty in the developing world that are relevant to this, to COVID, and how they interact with the prospects of avoiding the illness. Importantly, there's an overlap between these categories and the DHS Wealth Index. The DHS Wealth Index is a composite index formed from the first principal component of a huge number of variables in the DHS. And there's clearly an overlap. It's not a huge overlap. This is something that worried us early on in this project. There are hundreds of variables in the DHS Wealth Index that aren't in our index. In fact, 90% of the variance in the wealth index is due to these other variables. But nonetheless, there is an overlap, right? Which means that to some extent, the correlations with wealth are mechanical. They're coming from the overlap. But we don't think much of that. As I said, 90% of the variance is due to these other variables. Also, as a kind of precaution, we're going to stick to wealth quintiles. We're not going to use the cardinal values of the wealth index. And we think the wealth quintiles will be a little bit more robust to this concern, but we do have a concern about this. At the end of it, an important point to understand is we're not trying to identify exogenous variation in wealth. This is not we're not trying to identify a causal effect of wealth on our HEP category, our HEP index, Household Environment Protection, Home Environment Protection Index. We're not trying to identify the wealth effect causally, we're just descriptive. There are problems of missing values. As I said, we've got 54 countries with a lot of the stuff we want, but of course there are 40 countries with complete data on the 6 conditions. And even within those 40 countries, some households are missing values for some variables. And we got some worries about that, and we do some various versions of the index. The paper, by the way, it should be available to you, and there's this huge appendix which gives you lots of robustness checks and all of this stuff. We're also using another survey, also administered out of USAID and very much associated with the DHS, the Service Provision Assessment Surveys. Here we get, and this was a lot of work, what we're using is by geospatial methods, we're linking each of these clusters of DHS surveyed households to the infrastructure or the sampled infrastructure for healthcare within that country. So basically what we do is we do counts of the number of households. We set a limit of 5 kilometers. In the appendix, we do 10 kilometers. If you suggest some other number, we'll be happy. But our judgment was that 5 kilometers, particularly if you're sick, to get to help, to follow the treatment recommendations of the WHO and national governments, is reasonable. More than that does not seem reasonable. 5 kilometers seems okay. That has some limitations there. The big limitation, which is very unfortunate, is that this cuts us down to 9 countries because of missing GIS coordinates. We've also got some limitations here which we try to deal with as best we can. There's some literature on how to do this. We basically follow the Burgett and Posner's recommendations on how to do this linkage, and we're pretty happy with what they propose. Okay, what do we learn? Here, the first cut into this, I'm going to start with proximity to facilities. So this is just 9 countries: Bangladesh, DRC, Haiti, Kenya, Malawi, Namibia, Nepal, Senegal, and Tanzania. So this is giving you the proportion of households by wealth quintile for rural and urban areas the proportion who have a health facility. And by that, I mean a formal health facility. I don't mean a doctor's office or a pharmacy or traditional medicine or something. I mean a formal health facility within 5 kilometers of the primary sampling unit, which is a physical cluster. Think of that as a village, if you like, right? For rural and urban areas. Overall, for those countries, about 60% have a facility within this 5 kilometers. A strong wealth gradient, a large difference in rural and urban, not surprising at all. 46% in rural, 84% in urban. And this wealth gradient, which is, you can see here, is quite strong. So from the poorest, this is the poorest quintile. You're going to see this table many times, so concentrate on it now, please. Poorest quintile here. So we're seeing overall 39% of households in the poorest quintile have a formal health facility within 5 kilometers. You don't get to a majority till the third quintile from the bottom. Richest quintile, 88%. That rural and urban difference persists, although the proportionate differences and the absolute gaps are larger for poorer households using the wealth index. We're seeing a large difference between rural and urban there, between 35% of rural households in the poorest quintile versus 64% in urban. The wealth index should be comparable between households in urban and rural areas. I should have mentioned, I think it was on one of the slides, that the wealth index is country specific. It's a relative index within countries. That's what people do in this literature, and we're quite happy to do that. The paper gives you, and the appendix gives you country level estimates for all of this stuff. So I'm just giving you a gross summary of the results. Now, if we turn to the HEP index for 54 countries, so now we're using the full DHS and we're looking at the attributes I talked about. Has an internet, phone, TV or radio, 2 members or less per room, has a toilet, doesn't have to share, a wall and roof of any type, as long as it's solid, water source in the dwelling or yard, has a place to wash hands with soap. The overall HEP index are these red numbers here. So here, that tells you for the 54 countries, only 14%, these are all population weighted, only 14% of households comply with everything. Actually, since this, as I said before, there are some missing values for some countries. If we focus just on the 40 countries where we have complete data, that drops to 10%. Because obviously with the incomplete data, it's a bit easier to get a higher HEP index if you followed how it was constructed. So basically we're finding 90% of households across the developing world, across this 54 countries, about 90% don't satisfy. I'm not able to satisfy all of them. There's something in this list they can't comply with, one or more things. But here I also give you the breakdown by categories. Really striking, when you get to the poorest quintiles, we're looking at 4% of the poorest quintile, 8% the next poorest. Very few households amongst the poor in the developing world satisfy all of these criteria. For Sub-Saharan Africa, it's really striking. Let me just move this out of the way. We've got our 4% overall of the population of Sub-Saharan Africa satisfy all of the conditions we identified for compliance with the recommendations. When you go to the poorest, when you go to I was also going to highlight within our categories, big differences. This is better news here. We've got 81%, and I should go back a bit. If we look at this for the developing world as a whole, we've got 88% satisfy the learning condition, and that's good news. Almost 90% of households have some way of connecting up to get messaging and so on. But when you go to some of these other categories, and I highlight here the water source in the dwelling or yard, or has a place to wash hands with soap, the overall compliance rates in Sub-Saharan Africa are very low. Of course, you get to the poorest quintiles, it's very small indeed. And you get to the overall, the poorest 2 quintiles in Sub-Saharan Africa, it's virtually zero. Virtually no households can comply with all those conditions amongst the poorest 40% in Sub-Saharan Africa. Okay, so not bad news on learning. Isolation looks a lot harder. A majority of those in the poorest 2 quintiles have more than 2 people per room. That's per sleeping room. They do not have their own toilet. The vast majority across all wealth groups would have to leave their residence and yard for water. Hygiene is not looking too good. Focusing on hand washing with soap, we find less than half the sampled households can comply within the developing world, and less than 1 in 5 in Sub-Saharan Africa. Focusing on the poorest 40%, it looks even worse. Summarizing this, overall, 10% HEP index for the 40 countries with complete data, 14% for allowing for the incomplete data. 4% in Sub-Saharan Africa, for the rest of the developing world, about 18%. The numbers are alarmingly low. I mean, I've been working on poverty for 40 years now, and I was a bit surprised by some of this. For the poorest quintile, the index is only 4%, rising to 30% for the richest quintile, but only 30%. Among the poorest 2 quintiles in Sub-Saharan Africa, the index is virtually zero. Another point that stands out is the inequality in the HEP index by wealth, and this is really striking, particularly in Sub-Saharan Africa. And I'm going to show you the concentration curves here. The concentration curves are giving the cumulative share of households who are able to attain the HEP compliance, comply with the WHO conditions by wealth percentile. And you look at this, it's really striking. This is the HEP index for the concentration curves of the HEP index for Sub-Saharan Africa. You just see how far out it's bowed. It's, for example, in terms of wealth percentiles, the poorest 80% here can only get a cumulative share of 20% of the wealth of the categories in the HEP index. Looks pretty bad in Asia too, much better in Middle East, Eastern Europe, North Africa, and the Americas. So really, Sub-Saharan Africa and Asia, the health inequalities are huge. Here I've given you the HEP index for all possible values of K, if you notice the notation. So here we're saying, okay, maybe what we've said so far is you have to comply. Full compliance means you comply with all 6 categories. But you can have a weaker criteria. You comply with at least K categories, any K of those categories. And here I give you the results of the HEP index for different values of K, by wealth quintile. So this is a common thing we do in particularly multidimensional inequality and poverty measurement. But here I've given you the HEP index for different Ks. So if you look at K equals 1 here, we got virtually complete compliance. Well, K equals 1, this is basically driven by most people who have a dwelling with a ceiling and wall. Right? At K equals 2, not bad. It drops off dramatically at K equals 3 to 4, particularly between 3 and 4. As you see overall, look at the sharp drop. So we're seeing decent proportions who can satisfy half of the conditions. It's the pretty easy ones, obviously. The easy ones are having a dwelling and having the connectivity. Thankfully, connectivity, as I said, is pretty good. But with those 2 conditions, we get a lot of compliance. As soon as we start introducing water having your own water source, having particularly soap and water, things fall off dramatically. For Sub-Saharan Africa, similar story to other regions. Okay, across countries, we're going to start thinking now about, I've talked a bit about the variance within countries, what about between countries? And this is important because looking at the whole data set, basically 70% of the variance is between countries. 23% is accountable to wealth. And huge variance, HEP index of 0.003, that's 0.3 percentage points in Liberia and DRC, versus 75% in Armenia. Strikingly, there's only one country where a majority of the population pass all 6 conditions in our data set, and that is Armenia. for most countries, looks pretty bad. This is what it looks like. These are the country level estimates for the 40 countries with complete data. When I say complete data, I mean the 6 conditions that I talked about. Doesn't mean the data within the country is complete. There's some incompleteness there as well. Almost half of the countries have a HEP index under 5%. So for about half of the countries, they can't satisfy 95% of the conditions we've identified. 95% of households don't satisfy. Here I've given you a map. It's not very interesting map. I wish we had more countries, but you see it there. The darker the color, the higher the HEP index. What about the relationship with GDP? Very strong. I mean, for K equals 6, that's the full compliance HEP index. I've shown you the graph here. In logs, that's an elasticity of very close to 1. So basically, the HEP index has a GDP elasticity of 1, a 10% increase in GDP, a 10% increase in the HEP index. Of course, as you lower K, the elasticity falls. If you go into K equals 1, the elasticity goes to 0 mechanically. Just summarizing that, an elasticity not significantly different from 1, 0.93 overall. For K equals 4. K equals 4 is a kind of magic number a bit because of that fall off that I talked about. The elasticity falls to 0.43. Now, getting near the end here, but one important risk factor I want to emphasize, a set of risk factors we want to talk about. I mean, you would worry less about this if poorer households faced less risk of infection, risk of dying or risk of serious illness if infected with the virus. And that, of course, depends on health conditions previously and their age in particular. So we wanted to look a little bit at that just to see if there's any evidence that poorer households in the developing world are likely to be hit less. So we kind of milked the DHS data, trying to find as much as we could of the conditions that influence your vulnerability to illness if you catch it: age, obesity, HIV positive, pregnancy, heavy smoking. It's an incomplete accounting. We don't have diabetes or hypertension. What does that look like? This table summarizes by wealth quintiles. Essentially, 2 categories stand out where obesity and HIV positive, where the poor do have an advantage, if you like. These are characteristic health conditions prior to exposure to the virus, which influence your chances of surviving, which are a little bit more favorable, considerably more favorable to poor people in the developing world. Others, it's not so. Age, not at all. The age gradient goes the other way. The poorest quintiles tend to be older, and of course underweight, which is another risk factor. This table gives you both for men and women. Not everything identical there, but the underweight, the age differences similar for women. Obesity, a little bit less clear. Okay, conclusions on all of this. We think out of all this, and as systematic as we can be, it looks to us as something that maybe not a great surprise, but we now, I think, have a more confident empirical assessment. Global poverty is going to be a worrying thing from the point of view of exposure to this virus, as it is moving into the poor parts of the world. And you know, it's moving with huge uncertainties about data. I mean, the testing data it's been pretty bad in rich countries until recently. And this country, the United States, appallingly bad, but it's much worse across the developing world. We just don't have the testing being done or the tests. And separate to this, we're also looking at the ministries of health across a number of developing countries, and it's not a pretty picture. I think they're not well prepared in our view. Some exceptions, but not a lot. Limited scope. As I said, 90% of of households in the developing world cannot comply fully with the WHO recommendations. And there's a strong wealth effect in this. A very strong wealth effect both within and between countries. Conditions like having a place to wash hands with soap is not satisfied with the majority of the developing world overall, and only 1 in 5 in Sub-Saharan Africa. Summarizing all this, I'm going to leave time for questions, which I'm looking forward to, but we think the world's poor are really vulnerable to this disease. Of course, that's a vulnerability that won't be isolated among poor people. This thing is contagious. So poor people in the world could be the incubators for a spread into the population as a whole. But the poor, we think, are going to be quite exposed. What do you do? Well, a lot of thought. There's a separate paper I've written on policy implications on policy issues, but in many people. In that paper, I'm just drawing largely on what other people have said, but many people thinking about this. One point I'd really emphasize is the important complementarity between social protection and health policy in this context. And when you talk about the developing world here, it's really obvious. And cash and food transfers are going to be hugely important. Poor people can't afford to isolate. Very poor people living day to day, relying on casual labor, very little buffer stock. They're isolating the way much of the rich world is isolating is just not a feasible option. So it won't happen, so they will be exposed. Or if it does happen, they're facing a really tragic trade-off. And you think about it, if you've got 100% probability of starving at home versus a less than 100% probability of catching this disease, what are you going to do? You're going to leave home. So we're seeing a lot of further challenges out of this new paper. The current infrastructure for information does hold promise. We're very encouraged by this. I know it doesn't look great for very poor people, but overall, we're encouraged. So I think we push hard on this one, and I think it's a really important one, getting the information out, getting that connectivity going. And it's a two-way feedback, a two-way thing in information too, because many countries, there has to be reliable information. If the government is the main source of false facts in the country, this isn't going to work too well. And that's a worry. But if governments can also, even governments that are not performed terribly well in the past, could use this as an opportunity to raise their credibility, that would be encouraging. We also think some obvious things, subsidizing soap and water access in this period. This would be very easy to justify on economic terms. The external benefits, the equity impacts could be very important. We also think that there's going to have to be a whole lot of homegrown and innovative adaptations to the realities of life in the developing world. Developing countries are going to, if governments take this seriously, and they really have to, in our view, they're going to have to innovate. They're going to have to think of things that are cost effective, that can be done very quickly, that will try to deal with as best they can this huge infrastructure deficit of the home environments for protecting people in this period, combined with getting social protection out there on a significant scale. And a lot is happening in social protection, and we're seeing that. Coverage rates within countries are not looking so good, but we're seeing improvements. So there's some positive story there. So I thank you for your attention, and I ask you all to take care. Thank you. Questions? Gaurav, are you going to manage these questions?
Yeah, if maybe you could stop sharing your screen, and that may be a good idea.
Very good idea. You wouldn't believe I've been doing this for months now. Yes. Okay.
Okay. So yes, we do have some questions, and if any more come in, I'll try and pass them on as well. So let me mention the ones I've received so far. We have received so far, and let me mention them all together. And Martin, you could perhaps respond to this first set of questions. So there's one question which is basically asking whether it's possible to expand the number of countries using the Luxembourg income study data. and that would allow you to compare developing world with other countries. There's another question which asks whether it would be possible to consider results for k equal to 5, excluding in particular this requirement of 2 persons per dwelling. So the unit becomes really the household rather than you're looking at isolation between households rather than within households.
I'm sorry, I didn't understand that one. Can you repeat?
So it's saying whether you could consider results for k equal to 5 by dropping the requirement of 2 persons per dwelling, with the idea that you can focus on inter-household sort of spread of the virus rather than within the household. And then there is a question whether one can distinguish between proximity with the data. One can distinguish between proximity to a private versus a public hospital, with the idea at the back of it being that the urban and the peri-urban poor may live close to a private hospital but may not have the resources to access a private hospital, but only a public one. And then the question, there's another question which says that many of these index components are hard to change in the short run, and given that, what can governments do meaningfully to improve the HEP now? So that's sort of the first set of questions.
Okay, thank you very much. Yeah, I actually hadn't thought about using lists. Our view was that the information deficit was in the developing world. We've got so much going on in the developed world and so much research going on that we were trying to we were trying to equalize it a bit by focusing on the developing world. And the disease is spreading to the developing world, as I emphasized, in as yet unknown way because data is so poor. But so that's my only response to that. And I think I would continue to focus on the developing world. The second question is a misunderstanding. We're not looking at 2 persons per dwelling. We're looking at 2 persons per room, per sleeping room in the DHS. Yeah. So very much we're focusing here on the containment within the household. There's some interesting evidence. Jishnu Das pointed this out to me recently, but I'm not sure what's going on, but it looks like transmission rates within households are lower than I would have expected. But that's mainly work in China, but something interesting there. There's so many puzzles about this virus and this disease, and they're learning something new every day. How much intra versus inter? Clearly inter, huge. How much intra? We really don't know well yet. I would have guessed very high intra-household transmission and more than 2 persons per sleeping room, extremely high probability of transmission. But again, as I emphasize, this is something research is continuing on, and maybe some surprises ahead. I like this third, well, I like all these comments, but this third question about proximity to public versus private, I have to look into that. I don't know. Dominique is here, I'm not sure if she knows. We don't know, we'd have to look into that, but that's a good point, that poor people are really going to be much more relying on the public hospitals and public health care. It has to be formal, but it could be private. In principle, it could be private or public. So that's a good point. We'll look into that. And the fourth question, yeah, it is hard to change. That's our point. This is a big problem. We don't have any quick fixes. We think that a lot of innovation is going to be needed. Some of these things, like getting water and soap to people, as well as food and cash, are going to have to be a high priority. But a lot of this infrastructure stuff we're talking about, you're not going to suddenly change. Sorry. You have to know that reality and you have to adapt to it as best you can. Being aware of that reality, I think is hugely important to motivating action at this point. But yeah, they're not going to change suddenly. So other questions? Yes, we got.
Yeah, so we got one more question here, which says that what about big cities like NYC, London, where we can see highest number of COVID-19 deaths? In addition to the wealth index, are there any other correlates of HEP inadequacy or HEP adequacy? For example, female-headed households, ethnic minorities, they will be useful for targeting purposes.
Yeah.
Yeah, so that's sort of, and it goes on to say that I think we know that poor people will suffer the most if our goal is to understand the vulnerability points and interventions for reducing COVID-19. How important really is the household vis-a-vis the community variables? I would argue the best entry points for intervention will be market congregations, religious gatherings, and other social gatherings, public transport, infrastructure, architecture, etc. That's it. Yeah.
Okay. We haven't looked into other correlates as yet. We're asking whether the isolation, at this point, we're asking whether the isolation requirements or recommendations of the WHO, and you're not isolating if you in a market or in a large community group setting. The community action can come into it and has been. In fact, one of the striking things we're seeing from the reports we're getting from the phone survey, and this is not work we're doing, I'm just a consumer, is how much local community self-help groups, particularly in South Asia, Bangladesh, India, are helping. So in some sense, I agree in terms of the policy angle that they are going to be an important, for example, in Bangladesh, we're seeing this, actually reports that we've got from Bangladesh are suggesting that the NGOs that Bangladesh is famous for, and this was actually a study commissioned by BRAC recently, but which I had the opportunity to read, but that the BRAC study was suggesting that it's not BRAC, it's not the big NGOs that are present in the villages now and helping out. It's self-help groups, local community action groups. But I assume, and I certainly hope, they're doing this in a very careful way. This is not something where you organize a big Gram Sabha. That's not what's going to help. You're going to have to be isolated. It's more self-help groups in figuring out which families are in greatest need. Where is there a potential starvation problem, for example? Where would it help to get some food and soap to families? A lot of that going on, which is good news. And I think it's going to be very important. It's also going to be very important in that communication channel, particularly in the feedback aspects. And we're seeing this in Vietnam. It's been obvious. Local, through the app that the government created that's been very popular. Not just that pop song that went viral, but on COVID, but they created an app which people use for two-way communication. This is the government telling people on outbreaks of the disease locally, or telling people on remedial action or things to do. Important to isolate today, really important, for example. Plus feedback from local community groups saying, look, things are broken out right here and we need help. That sort of thing done through mobile phones can be really effective. You just need governments like the government of Vietnam, who acted right from the beginning. I guess the SARS experience had them in tune with the importance. But this has to happen across the developing world. This is in the countries in Sub-Saharan Africa. Ministries of Health need to start mobilizing on this, or governments, to create the basic communication infrastructure. I can't emphasize this enough, particularly since a lot of these things are not going to be easy to change, as the fourth person asked. You're going to have to rely a lot on communications, and it's probably going to be mobile phones, and it's probably going to be texting. You can do stuff with cute videos. My favorite, the Uganda video on COVID is fantastic. The Ministry of Health produced. It's just hilarious and it's great. More of that, please. But particularly through text messaging, I think is the thing that sort of shows the most promise for reaching poor people.
Okay, we have some more questions for you, Martin. There's one which says, how should developing countries approach the lockdown if isolating is not feasible? What do you recommend for developing countries? What do you recommend developing countries should do in that situation?
If isolation is not feasible, how would lockdown be feasible?
There's two separate questions here. So,
I'm sorry.
One question which is asking you how should the developing countries approach the lockdown, and then another question asking if isolating is not feasible. What do you recommend developing countries should do?
Yeah, this is why at the end there, and it's I've got a paper on the called Pandemic Policy in Poor Countries on the Center for Global Development website. Which goes more into this, but it's why I was emphasizing the importance of the complementarity between social protection and the healthcare policies, particularly in poor places. And if you can't do the social protection side of this, it's not just lockdown is going to be problematic. Lockdown won't happen. It just won't happen. I mean, it can't. Maybe you'll clear the main arterial roads or the main streets in cities, but people can't lock down if that. Very poor people, lockdown is equivalent to destitution. It won't take very long. So once you realize this obvious fact, this is not going to happen. Moderate social distancing and sensitivity to that is something that you teach people through the information channels I've talked about. Moderate social distancing can be done without the costs of lockdown. I think lockdown is potentially very dangerous. And it's also not just from the point of view of individual households and the problems they face feeding the family. It's also a lockdown of institutions and markets. Once you talk about that, you're talking about something very dangerous. Once food markets, if the food system was locked down, it won't take long in very poor places to produce a famine. And you obviously don't want to do that. So the adoption of lockdown policies, what I saw in India, thankfully reversing it somewhat, but the adoption of lockdown policies in poor places, really got to think seriously about that. If you can't do effective social protection, and if social protection has been a huge challenge, particularly getting transfers in cash and kind to poor people. It's a challenge the developing world is doing better at over time, and that's good news, but still not very well. I mean, our estimates that we've done another paper with Walle, the results are very alarming. I mean, the poorest people in the developing world, yes, there's been a huge expansion in social protection, but the poorest people are not getting much protection. So, okay, great. If you can combine social protection with health policy interventions associated with isolation and even lockdown, it'll work. But if you can't, and I'm skeptical, it's not going to work. The lockdown just won't work. It won't work for poor people. So they'll be exposed. That's the reality. Okay, I think I answered that. I'm not so sure if there's anything to follow up.
Further questions which have to do with further geographical disaggregation of this exercise, either at a regional level, or there is a question also saying that, or making a comment and hence asking the question, that the distinction between rural versus urban may not reflect the importance of divisions within the rural. In particular, is it possible to disaggregate data to see the situation in densely populated urban slums?
Yeah.
And is that partially captured by differences in income groups within the urban areas?
Yeah. Now, that's actually a good question. It's something we addressed briefly in the paper, but something Kate, Dominique, and I have been looking at even today. But what we do know so far is that the wealth gradient is not due to density. In other words, we run a regression of the HEP index against wealth index and population density. The wealth index effect remains strong. But population density is obviously important, no question. We'd love to do more disaggregation. I'm not sure if that was two questions or one question. And that's something that, it's only only today really that we've started, the last 2 days, we've started to have, got things sorted out with the geospatial stuff. And as I said, we're still rather restricted on the number of countries. But that is something to look at further. But maybe for some of the bigger countries. At this point, we're just putting something on the table, which is the beginning of hopefully of some further research.
Okay.
Other questions?
I think that's pretty much the set of questions we have at the moment. If I may use my privilege and ask you a question, Martin, as well.
Yeah.
I think, and there's the other angle to this issue is, of course, that, one is the ability to comply with the sort of measures that are needed to protect for the people to protect themselves from the virus. The other side, as you know, is the economic situation, which may compel people to not to comply, in the sense that they need to go out. I mean, which is the point about you made about social protection and so on. So even if they have the ability, there may be circumstances where even with a high index in terms of the HEP index, they may be non-compliant simply because people don't have another way to survive. So they need to go out and do whatever they need to do, procure food or whatever, try and earn a meager income or something. So it might be quite useful to complement this with that side of things, which up to a point we can do actually with, we can put some numbers on that with the survey data that we typically have. So just a point in that regard.
By all means. Well, our starting point was that was already covered and we're moving to the next step. And you're presenting that as the next step, but we thought basically that's pretty covered, well covered. But there's so much going on, so many people working on this, and mostly not in the developing world, as I said, but increasingly so. I think, well, in our thinking, that survey paper I referred to gives you more links to literature and links. A lot of literature isn't really literature; it's blogs and even tweets. But so I think I've been trying to keep my finger on the pulse of this, but I have a feeling that I thought we were kind of pretty much decided that was the whole issue of, can you afford to comply, the economics of this, partly because of the analogous issues in rich countries, and what we've seen, that the hardship this is creating for very poor people, the huge unemployment rate in this country now, the problems we're seeing. So our feeling was that, and that was fairly obvious. I guess partly also because of the literature in India and the writings of people like Jyoti Ghosh, Jean Tres, others. We thought that people had raised these issues pretty well. So we turn to this issue of the feasibility of the home environment. But you need, of course, both sides. We're not saying that it's only about the home environment. It's obviously these behavioral responses are going to be very important. Your ability, whether the home environment is appropriate to compliance, but also whether you can afford to comply. And that's why I put so much emphasis on the complementarities between social protection.
Okay, there's one more question. If we've gone over our time limit, but if you want to,
that's fine.
That's fine, is it?
Yeah.
There's a question which says, on aggregation, do you have any information on differential vulnerabilities of women?
Yeah.
Yeah.
That table I showed you had both men and women on the risk factors, and there are not a lot of differences actually. Women are more obese, for example, but and that's a risk factor. Men tend to be older. That's a risk factor facing men. But it's something we've talked about and something Dominique has thought a lot about, I think, but we haven't got much more to say at this point.
Okay. Well, we might try and bring the proceedings to a close at this point. So let me actually, first of all, thank Martin for the presentation and his thoughts and also his responses to various questions. I mean, I think, this is a topic we're going to be talking about and thinking about for quite a while. So it's good to kick off some initial conversation and let me, on behalf of the center, thank everyone for joining in. And if you have any further questions, you don't feel free to send them to us through our web address. And if you have further questions for Martin, we'll be happy to also pass them on to Martin. Of course, you can write to Martin directly.
Or you can just write to me directly.
Yeah.
And also let me take this opportunity to thank everybody for participating and for commenting.
Okay, so with that, thanks everyone, and hope that many of you will join us for some of our future events in the coming weeks, and more information on that is available on our website. So thanks again, everyone. Bye for now.
Thanks, everyone.
Bye. Take care.
Thanks.
Thanks, Martin.
Thank you.
Thank you.